Have you ever looked at a medical bill after maybe just a simple X-ray and thought, what is all this? It feels like a secret code sometimes.
Right. Or you picture the doctors looking at those, shadowy images, searching for that one clue.
Exactly. Well, today we're actually going to dive into that world. It's the surprisingly complex world of radiology coding.
Mm-hmm. And we've got some really good foundational material here. It breaks down how these common procedures get classified and coded, mainly using the CPT system.
CPT, current procedural terminology. That's kind of the official rule book, isn't it? For talking about medical procedures for billing and tracking.
That's the one. Our source material is basically an introduction to the radiology section of that CPT manual. It gives a structured look at how medical imaging is organized and some key coding principles.
Okay, so our mission today is to try and crack that code a bit. We want to get to those, aha moments about why certain scans get certain codes.
And how that all flows through to the bill eventually.
Right. And don't worry, we promise not to drown you in super technical jargon. We're just pulling out the most important and hopefully interesting parts.
Sounds good. Where should we start? Maybe the overall layout.
Yeah, let's start there. How is the radiology section in the CPT manual actually organized?
Well, what's interesting is it mostly follows anatomy. It's not perfectly head to toe, but generally it starts up top and works its way down.
Okay, so like head first.
Pretty much. Head and neck is the first big category, and that includes, the obvious like jaw imaging, but also sinuses, even complex things like CT scans of the brain.
Right, quite broad for just head and neck. What comes after that?
Then it moves down to the chest, then the spine and pelvis.
Ah, spine and pelvis. The source mentioned something specific there, didn't it? About bending views.
It did. Bending views for scoliosis, which is a great example showing it's not just what part you image, but sometimes how you image it that matters for the code.
That's a really good point. The technique matters too. Okay, so after spine.
Then you've got upper and lower extremities, arms and legs. Then into the abdomen, GI system, urinary, GYN, obstetrics.
Yeah.
And the heart gets its mention too.
It's like a quick tour of the body's main systems through imaging codes.
It really is. And this anatomical grouping, it just makes it more efficient, logically consistent. After that general sweep, it gets more specific with vascular procedures.
Yes, the vascular stuff. That seemed to have its own dedicated focus.
Definitely. It covers everything from the big aorta down to tiny arteries, veins, lymphatics.
The source listed examples like lymphangiographies
Mm-hmm.
and shuntograms.
Exactly. And venographies, transcatheter procedures, basically the body's plumbing system gets special attention.
Makes sense. And then ultrasound came next, right?
Yes, diagnostic ultrasound. And again, notice the anatomical breakdown. Head, neck, chest, abdomen, spine, pelvis, OBGYN uses, genitalia, extremities.
It seems like they slice it pretty thin category-wise.
They do. And it also includes using ultrasound for guidance, like for needle placements or amniocentesis.
So guiding other procedures.
Right. It shows how one technology gets categorized based on where and how it's used.
That level of detail is really something. Does it stop there?
Not quite. There are also sections for other guidance methods like fluoroscopic, CT, MRI guidance, plus mammography, bone and joint studies, and then the whole field of radiation oncology. It's pretty vast.
Wow, okay. It covers a lot of ground.
And remember, it's not just the imaging itself. The radiology section also includes codes for things like consultations and treatment planning.
Ah, right. So the thinking part, not just the picture-taking part.
Exactly. The source mentions these are classed as simple, intermediate, or complex.
And you need to check the CPT definitions for what makes them simple versus complex, I imagine.
Precisely. It's not just reading the image, but the whole cognitive process around it.
Okay. What else falls under that umbrella?
Well, then you get into more specialized areas. Medical radiation physics, dosimetry, which is calculating radiation doses, treatment devices, special services.
Feels like we're getting into the really technical side now.
A bit, yeah. Then various radiation delivery methods, stereotactic, neutron beam, proton beam, even things like hyperthermia and brachytherapy.
Proton beam. That's the really focused radiation, right?
Generally, yes. Often used for precise tumor targeting. Then there's nuclear medicine diagnostics broken down by body system. And finally, therapeutic radiology. It just shows the massive scope.
It really is a comprehensive catalog. Okay, so that's the CPT side. But our source mentioned the diagnosis codes too, the ICD-10-CM codes. How do they fit in?
That's a really crucial interaction, especially for radiology, because often when an image is ordered, there isn't a firm diagnosis yet.
Right. So The coding might start based on just symptoms.
Exactly. The example used was wrist pain. Someone comes in with wrist pain, gets an x-ray. Initially, the code might just be for, well, wrist pain.
Okay, makes sense. But what if the radiologist looks at that x-ray and finds, say, a clear fracture?
Then the radiologist provides that definitive diagnosis, wrist fracture, and that diagnosis gets reported.
Ah, so the diagnosis code can change based on the findings.
Yes, but there's a key rule the source highlighted for professional fee coding. You can't code things that are just questionable or possible.
Needs to be pretty certain then.
Right. You need a solid finding.
Got it. And there was a specific code mentioned for routine x-rays, wasn't there? When there aren't symptoms.
Yes. Z1.89, that's encounter for other specified special examination, used for, like, screening x-rays or checkups, not investigating a specific problem.
Okay. Good distinction. Now, shifting gears slightly. To understand these reports, you mentioned anatomical planes.
Yeah, absolutely. If you've ever looked at an MRI or CT, understanding the planes helps make sense of it. There are three main ones.
Let me guess.
Sagittal.
That's one. Sagittal is like looking from the side, cutting down the middle.
Okay. And frontal. Or coronal.
Right. Frontal or coronal is like looking straight on, face-to-face view.
And the last one. Transverse.
Transverse, exactly. Like looking down from above, a cross-section. These are the basic viewpoints.
Helps visualize what the radiologist is seeing.
Definitely. And related to that are directional terms. The source mentioned proximal and distal.
Proximal meaning closer to the body or attachment point.
Spot on. And distal means further away. So if a report says something is distal to the knee, you know it's down the leg towards the ankle or foot.
It's like a GPS for the body.
Mm-hmm.
Okay, now what about this supervision and interpretation, or S&I? Sounds collaborative.
It often is. S&I codes are used when radiology is needed to guide a different procedure, like a surgery or medical intervention.
So you have the code for the main procedure and then an S&I code for the radiology guidance part.
Precisely. Think about maybe a biopsy deep inside an organ.
Okay.
A doctor might use ultrasound in real time to guide the needle. The biopsy itself has a code, and the radiologist's work guiding that needle with ultrasound, that's the S&I code.
Ah, I see. So the supervision and the interpretation of the images during the procedure.
Exactly. And how it's coded depends on who does what.
How so?
If the same doctor does both the main procedure and the guidance, they usually report both codes, the main one and the S&I one.
Okay.
But if it's two different doctors, say, a surgeon doing the procedure and a radiologist doing the guidance, then the surgeon bills their code, and the radiologist bills the radiology and S&I codes for their part.
Right, so it reflects who did which piece of the work. That makes sense. Okay, let's talk contrast material. Heard that term a lot.
Yeah, contrast helps make certain things show up better on scans. It enhances visibility.
But the source made a key point about how it's given, Ray.
A very key point. Oral contrast, the stuff you drink, or rectal contrast doesn't count for, with contrast coding in CPT terms.
Really? So what does?
The with contrast label applies specifically when it's given intravenously, like through an IV or intratactically, into the spinal fluid.
Okay, big difference. So drinking it is coded differently than getting an injection.
Correct. And usually the cost of the contrast material itself is billed separately anyway, using different codes, HCPCS codes.
Got it. Okay, next up, TC and 26 modifiers. These sound important for billing.
Very important. They separate the technical part from the professional part of a service.
So TC is technical component. What falls under that?
TC covers the equipment, the x-ray machine, the MRI, plus the staff running it, the supplies used. It's the physical doing of the scan.
Like taking the wrist x-ray in our earlier example, the machine and the tech.
Exactly. That's the TC.
And 26 is the professional component.
Right. That's the doctor's work. Interpreting the images, making the diagnosis from the scan, and writing the report.
So the radiologist identifying the fracture and documenting it, that's the 26 part.
Precisely.
And sometimes one place does both, like an urgent care.
Yeah, or a specialist like a cardiologist who owns their own ultrasound machine. They might bill globally, covering both, or use the modifiers depending on the situation and payer rules.
But the source warned about using them correctly.
Yes, because some CPT codes already only include the professional component. You can't just add these modifiers everywhere. You have to read the code description carefully. It depends on ownership, employment relationships. It gets complicated.
Sounds like you really need to know the specifics of each code and situation.
Absolutely. Misusing them leads to billing errors.
Okay. The source also briefly mentioned the 90,000 series codes, like for EKGs. What was the takeaway there for radiology coding?
It was mainly an illustration. That series shows clearly how some codes bundle everything technical and professional, while others are just for one part. The lesson, which applies across the board, including radiology, is read the code description. Always. Know exactly what that specific code covers.
Read the fine print. Always good advice. Okay, one last detail the source highlighted. The number of views for X-rays. Seems simple, but apparently crucial.
It is crucial for picking the right blend. Many X-ray codes specify the number of views needed, like 2 views or minimum of 3 views.
And that minimum is important.
Very. If a code says minimum of 4 views, like the mandible X-ray example,
Yeah.
then taking 4, 5, or 6 views still uses that same code. You met the minimum. There's no extra code just because you took one more view than the minimum required.
Oh, okay. So you just need to meet or exceed the minimum stated in that code.
Exactly. The coding reflects hitting that threshold.
All right. Let's try to wrap this up. We've covered quite a bit in this deep dive.
We have. From the anatomical structure of the CPT section
To how diagnosis coding works initially with symptoms versus later with definitive findings.
the role of S&I codes for guidance, and those TC and 26 modifiers separating the machine from the interpretation.
And even details like IV contrast versus oral contrast and counting the number of X-ray views.
Hopefully connecting this back to you, the listener, this gives you a clearer picture of what goes on behind the scenes with medical imaging and billing.
Yeah, maybe makes those bills a little less mysterious. Understanding the logic can definitely make you feel more informed about your own healthcare.
It's more than just pushing a button, that's for sure.
Absolutely. The organization and detail are really quite something. So, here's a final thought to leave you with. We're seeing huge advances in AI, artificial intelligence, especially in analyzing medical images.
It's a rapidly evolving area.
So how might that AI revolution potentially change these coding structures we've talked about? What happens to the value or the definition of the technical component versus the professional human interpretation component in the future of radiology?
That is definitely something to think about. How does AI fit into this framework?
Exactly. Food for thought as technology continues to reshape medicine.